Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic. Today we will be talking about calcium pyrophosphate deposition disease, or CPPD disease, which is under the Rheumatology banner as part of your MRCP revision. So, what is CPPD disease? This is a condition that can range from asymptomatic radiological findings to a disabling polyarthritis, so quite a big range of symptoms and signs, and it is due to the deposition of calcium pyrophosphate crystals, as the name suggests. So it's thought that approximately 8% of people have evidence of calcium pyrophosphate deposition on X-rays of the knee, for example, and this actually rises to 14% if you include hand and pelvis X-rays. However, crucially, not all of these may be clinically important. It tends to be a disease of the elderly, with onset and frequency increasing in people over the age of 50. If under the age of approximately 55, it's a good idea to check for familial or metabolic disease, which may be underlying this condition, or indeed any evidence of previous joint trauma or meniscectomies. So, as we've already said, this is due to the deposition of calcium pyrophosphate crystals in and around the joints. It's usually idiopathic and is age-related. It can occur in certain metabolic disorders in the presence of hypercalcemia or hypomagnesemia. Risk factors include advancing age, as well as underlying primary osteoarthritis, and it can also be familial, especially in young onset CPPD disease. Usually this would present in someone aged between 20s and 30s, and they may have spinal involvement, which is quite unusual otherwise. So there's several disease associations with this condition, some of which are listed here, and they include primary hyperparathyroidism, long-standing hypomagnesemia, hypophosphatasia, hemochromatosis, Wilson's disease, Bartter syndrome, and onchronosis. Calcium pyrophosphate deposition disease can be classified under 4 main headings. So firstly, as we said at the beginning of this presentation, it can be asymptomatic. So this is where you have radiological changes, or radiological evidence of chondrocalcinosis more specifically. And this is actually prevalent in up to 30% of people over the age of 80 years. But of course, not all of them are presenting with painful or acutely swollen joints. Secondly, it can lead to an acute monoarthritis or an acute hot joint. And this is more commonly known as pseudogout, which is the typical disease subtype that most people have heard of. And this usually affects the knee, the shoulder, or the elbow. Thirdly, it can cause an inflammatory polyarthritis, and this is quite a good mimic of rheumatoid arthritis and accounts for about 10% of CPPD cases. And finally, there is the form that occurs with osteoarthritis, and this affects the hips, the knees, the index and the middle MCP joints, so generally the areas where osteoarthritis would also affect. So CPPD disease is a differential diagnosis for a hot joint, particularly when it presents as an acute monoarthritis. and it should be considered in any acute or chronic mono, oligo or polyarticular inflammatory or non-inflammatory arthritis in people over the age of 50 years in particular. So now we're going to focus a little bit on pseudogout in particular, as this is the most common form that you're likely to encounter in clinical practice and also likely to be asked about in the exam. So this comprises an acute arthritis with rapid onset pain and swelling, and typically presents with a warm, swollen, erythematous and tender joint with an effusion. To compare it with gout, it does tend to be less painful and longer to reach peak intensity than gout, and usually affects a single joint, the knee and the wrist most commonly. Again, in comparison to gout, the first metatarsophalangeal joint is only rarely involved. And it's important to note, particularly in clinical practice, that septic arthritis can coexist in 1% of cases. Joint aspiration is key for these patients, and on aspiration you'll notice that the fluid is yellow and cloudy and may even be opaque and chalky, and this is reflective of the leukocytosis which is within the fluid. On polarized light microscopy, the crystals are seen as weakly positively birefringent rhomboid crystals, as demonstrated in the image. And you will remember that this is in stark contrast to the gout crystals, which are negatively birefringent and needle-shaped. It's important to know the difference between these two, as it is a classic MCQ question, but also for interpretation in clinical practice as well. X-ray features can be quite striking in this condition. So we can see here that there is chondrocalcinosis within the joint space, which is the sort of wispy, cloudy substance you can see within the knee joint here. Up to 20% of patients, however, with pseudogout may not have chondrocalcinosis on their X-rays, and it's important to bear that in mind, which again comes back to why aspiration is so important. Coming on to the management of pseudogout, untreated pseudogout can actually be self-limiting in most cases, usually within 7 to 10 days, and people tend to be asymptomatic between attacks. However, if there is significant pain, then NSAIDs can be used for the arthritis, and it is important to correct any underlying metabolic disturbances where possible, which can be leading to the calcium pyrophosphate deposition. One can consider oral or intra-articular steroids if avoiding NSAIDs, or if there is evidence of non-resolving disease. So let's try some questions now. So which of these conditions may predispose to calcium pyrophosphate deposition disease? So if we think back to that long list of possible metabolic underlying abnormalities, and other conditions that was towards the beginning of this slide set. Our options are Liddle's syndrome, hypoparathyroidism, hyperthyroidism, Bartter syndrome, and rheumatoid arthritis. So the most correct answer in this case is Bartter syndrome. So now coming to the second question, an 80-year-old gentleman presents to A&E with a 3-day history of an acutely swollen right knee. It is warm, red and tender to touch with a large effusion. So this is by no means an unusual scenario actually in acute medicine. The joint is aspirated as per good clinical practice, and the treating doctor concludes a diagnosis of pseudogout based on the joint aspiration as well as an X-ray of the knee, which shows chondrocalcinosis. So, what does the synovial fluid analysis show under polarized light microscopy? So our options are positively birefringent needle-shaped crystals, positively birefringent rhomboid crystals, negatively birefringent needle-shaped crystals, negatively birefringent rhomboid crystals, or hydroxyapatite crystals. So those of you who've watched the previous episode will recognise this set of answers, because one of these is descriptive of gout Another is descriptive of pseudogout, which is what we want in this case. And the others are not very relevant in this particular question. The correct answer in this case is positively birefringent rhomboid crystals. And the final question, which of these joints is not usually affected by calcium pyrophosphate deposition disease? A, the first MTP joint, B, knee, C, the wrist, D, the elbow, or E, the shoulder. So the joint that's least likely to be affected is the great toe, or the first metatarsophalangeal joint, which in comparison is usually affected by gout. So that brings us to the end of this episode of Bite-Sized MRCP. Thank you for listening. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. And let us know in the comments which topics you would like to hear in future. And we look forward to seeing you for our next episode.